Lymphoma is a major cancer diagnosis in Southern Africa. Today we discuss the approach to lymphoma diagnosis. When we look at cancers, it's important to look at the cell of origin that gives rise to a cancer. And when we speak of lymphoma, we can see that it's the B and the T lymphocytes that are end cells of the hematopoietic system that will give rise to different lymphomas at different stages of their maturation. Blood is like a river, and blood is ever changing, ever moving. So is it strange then that lymphoma is a very, it's a cancer that hides, that doesn't show itself, that assimilates with its surroundings. And if we look at this picture, we can see that there is not one, but actually two women hidden in this picture. And in the same way, lymphoma plays hide and seek with a diagnostician, with a healthcare worker. It mimics many other diseases, and it is very difficult to pinpoint where to make the diagnosis. So let's look at the two places where a lymphoma may be found. I am not going to focus on the blood today. That is a whole different topic. Let's just look at the lymph nodes, which would be the natural home for the lymphocytes and where a cancer of the lymph cells will start. So we can see that what we would typically expect would be, in South Africa, in our region, would be the mycobacterial causes of lymphadenopathy, as well as, sadly, due to late cancer diagnosis, metastatic cancer in the lymph nodes. But what we are going to chat about today is that actually hematologic causes of lymphadenopathy rightfully takes a very, very important place. After all, it is the home of these cells. So if they would become cancerous, that's where you will find lymph node cancer or lymphoma. So Hodgkin disease and non-Hodgkin lymphoma are the two diseases, the two big groups that we look at. If we look at an approach to the other site or other major site of lymph node masses that we cannot afford to miss it, would be the mediastinum. And again, there is the common perception in South Africa that tuberculosis would be a cause of a mediastinal mass, or lung cancer or metastatic cancer would be a cause of a mediastinal mass. But actually, again, we find that the hematological causes of a mediastinal mass is quite common, and the younger the patient is, the bigger the chance that it will be lymphoma. So if there's one thing that I want to really make very, very clear today, it's that patients with, that are young with a mediastinal mass, less than 40 years old, they will have a lymphoma until proven otherwise. That doesn't mean that the older patient with a big mediastinal mass cannot have lymphoma, but then other things like metastatic cancer will be competing for diagnosis. So again, let's start at the evidence. Why are we speaking about lymphoma? We are looking at the GLOBOCAN World Cancer Statistics for 2018, and we can see that if we look at the male-female cancers and we divide it into two groups, then actually non-Hodgkin lymphoma is number 5 on the list for both sexes. So it's a very common cancer. And if we look at the picture below, we can see that actually these are cancers with reasonably good chance of surviving in the year of diagnosis. So non-Hodgkin lymphoma, number 5 on the list, and if we look at the slide below, we see that it moves down on the mortality list, that actually the chance of mortality becomes a bit smaller than, for example, other cancers like lung cancer or colorectal cancer. So lymphoma is number 5, also in the UK. Let's look at this data. If we look at men, this is a slide for men, but we can also look at women with breast cancer. It remains number 5, so it remains an important cancer. But then we also see, if we look at the world statistics, that non-Hodgkin lymphoma is at number 5, if we put prostate and breast at number 1 for both sexes. But let's just show how widespread and how important the different hematological cancers are. Some lymphomas are actually leukemias, like CLL. So amongst the leukemias in this slide would also be lymphomas. Myeloma is actually a lymphoma, and Hodgkin lymphoma is obviously a lymphoma. So we can see that there is much more than just non-Hodgkin lymphoma in our cancer statistics. And let's look at these figures of incidence in 2018, and let's actually go and put these numbers together. And then we actually see that total blood cancers were 45,000, actually 46,000 in the UK. And now we see that we actually are passing colon and melanoma, and we actually become, and this cancer actually becomes number 3 hematological cancers on the list of global cancer statistics. So now we switch gears a tiny bit and we just look again at the net survival, because I really today want to explain that there's a reason we want to diagnose lymphoma, because patients actually with treatment have very good survival. So let's show Hodgkin lymphoma is actually number 3 amongst men, and is only really superseded by skin cancer and by the very early germinal cell cancers like testis cancer of men. So it's really an important cancer with basically one of the best survivals. And if we look at non-Hodgkin lymphoma, then we see it's also in the top 6 of good outcomes. So very, very important cancers for women. These 2 lymphomas are in the top 5 of good outcomes. So they are right up there with breast and uterus cancer. So traveling on the pathway to lymphoma diagnosis and treatment, you can take different roads, because lymphoma, that's where we started out, is actually a disease of a lot of different cells at different stages of maturation. And the younger these cells, when the cancer strikes them, the more aggressive the lymphoma will be. The more mature the cells are, the more indolent the lymphoma will be. So let's look at the indolent ones, the low road. Low-grade or indolent lymphoma, and common examples I'm giving today are CLL and follicular lymphoma. Then let's look at the very high grade or the very aggressive ones. These lymphomas take the plane, and we have to take a plane to get to them, to treat the patient in time. And good examples of these would be ALL and Burkitt lymphoma. And then the middle road, which is actually the high road in this case, because they are high grade, they're aggressive lymphomas, are the Hodgkin lymphomas, diffuse large B-cell lymphoma as the most common counterparts of this type of lymphoma, and then peripheral T-cell lymphoma, a smaller group, but still a very, very important group of lymphoma. So I am now going to chat about the high road lymphomas, or the high grade or aggressive lymphomas, and it's my job today to actually convince you how important these lymphomas are and how important that we diagnose them at the right time so that they can receive the right treatment. So let's look at Hodgkin, DLBCL, PTCL, and I like to call them il buono, il brutto, and il cattivo. And that obviously comes from a very well-known movie that it's about 30, 40 years old. And it was a spaghetti western, very well known, and the story goes, there were 3 bums going around through the Civil War looking for money. So if we make that analogous to our lymphomas, then we will say this is the story of 3 aggressive lymphomas looking for a cure. So il buono is Hodgkin lymphoma, il brutto, B-cell non-Hodgkin lymphoma, the most common, as we said, DLBCL, diffuse large B-cell lymphoma, and then il cattivo, the bad one, the ugly one, is peripheral T-cell non-Hodgkin lymphoma. And there are various examples. I think the ALK positive and aplastic large cell lymphomas are reasonably common. Then there are those that we can't typify further, and the angioimmunoblastic lymphomas. Good, so let's start at il brutto, DLBCL, most common aggressive B-cell lymphoma. And let's look if we can find which factors will determine the outcome in this lymphoma. We use prognostic scoring indexes, and we can see that the stage of the lymphoma, as in Ann Arbor, is important. The more advanced stage, the poorer outcome, whether the patient has A or B, has B symptoms or not. And then prognostic factors, and we'll talk a bit more about that later. So let's just look at the CHOP effect on DLBCL, and we will see that if a patient is in an early stage, they have a 73% chance of long-term survival, but late-stage disease is more like 26%. If we add rituximab to the mix, we see much better outcomes. It's also more modern outcomes, more recent. We can see that early-stage disease with low prognostic factors, these patients have a very good chance of long-term overall survival, around 90%. And the more advanced ones are again in the 50s. So I said I would look at the prognostic factors a bit more, because that's very important. We care about these factors because they are going to tell us how well our patients will be doing. So age, more than 60, is a given. We all know that. LDH, that's raised, that is also a poor prognostic factor. The stage, as we've already said, if it's a more advanced stage. If the lymphoma has had time to grow into extranodal areas, that also makes the disease more dangerous to the patient. And then one very important factor that we sometimes forget, what is the performance status of our patient? And that is probably a reflection of a few different things, the patient's own comorbidities, but also the aggressiveness of the lymphoma, as well as how long the patient took to get to diagnosis. So, if we now have concluded from these results that advanced stage of disease and performance status, poor performance status, takes prisoners, then what is our key to better outcomes? Access to rapid diagnosis. So that is what the theme of our discussion today is. We sometimes reflect to the patient with lymphoma this weird contradiction. Come in, we'll help you, but actually we're close to diagnosis. And then at the time that we actually make the diagnosis, we have to say to the patient, sorry, we are open, but too late. So a patient with lymphoma should never arrive in a horizontal position, should not arrive barely able to get out of bed. That immediately puts the patient at risk of poor response to treatment. So let's look at the other high grade, il buono, the good one. And here we have a young man, typical age group for Hodgkin lymphoma, and we will see that he was complaining for months at a secondary hospital with chest pain. And if you look at the left, the area just above his clavicle, you can actually see there's 2 bumps there. But what sometimes happens with such a patient is that the lymph nodes may have been small in the beginning, was missed, and then is not necessarily examined at subsequent visits. And we can see that this young man complained and complained of pain, and if you use a bit of imagination, you can see that the lymphoma is growing right through the sternum. He was on morphine drops, as well as obviously using the big treatment of our age, cannabis oil, by the time he got to us. And can we blame him? Because it was excruciating to have a lymphoma grow through his sternum. But if they had done a chest X-ray and seen a mediastinal mass, or examined him again, they would have found the lymph nodes and actually gotten him for diagnostics for either his lymphadenopathy or his mediastinal mass. So we've already spoken about DLBCL. We revisit, just for refreshing our memory, the good outcomes seen with rituximab plus CHOP. Let's look at Hodgkin. So the modern outcomes of Hodgkin, we see that if the patient has low risk score, so this is the risk score for Hodgkin lymphoma, that the long-term overall survival is excellent. It's almost 100%. If this risk goes up with more advanced disease, then we can see that the patient still has a 2 out of 3 chance to survive long-term after treatment. So we looked at these 2 diseases in our own setting. And we first looked at our patients with aggressive lymphoma, 163 of them treated a few years ago. And we found that diagnostic delay was associated with late-stage disease, and strangely enough, with Hodgkin lymphoma. And guess why that was? Because Hodgkin lymphoma presents more often with peripheral lymphadenopathy than DLBCL, and where that should have enabled diagnosis, it had exactly the opposite effect, namely, diagnosis was delayed because indiscriminate fine needle aspiration cytology was repeatedly performed in patients with Hodgkin, and empiric TB therapy was given. So in that case, the lymphadenopathy disconnect in our approach definitely disadvantaged these patients. We looked at the fine needle aspiration cytology in all these patients, and in only 11% of these lymphomas, did it actually contribute to diagnosis. But it did contribute in a major way to disinformation, because doctors saw negative or reactive cytology, and they never realized that aspiration cytology of a lymph node is the poorest way to diagnose a lymphoma, unless you are part of an absolutely fantastic lab specializing in cytology, doing fantastic tests and stains. Then you can diagnose a lymphoma on fine needle cytology, but definitely not the aspiration we do in the wards, and without specific proper care and focus on lymphoma diagnosis. So we can see that actually our patients who were HIV negative with Hodgkin did reasonably well. Remember, that's the whole group. It's the good risk and the bad risk HIV negatives, and we can see how well Hodgkin lymphoma, even in a community-acquired setting, does. But then we can see in the bottom 2 survival curves that for the non-Hodgkin lymphoma patients, those with HIV were definitely very, very badly impacted. So we'll speak more about that a bit later. Then more recently, we also looked specifically at the DLBCL patients, and we can see here that patients who were HIV negative did not have a statistically different outcome from those with HIV positive disease with adequate CD4 count. So if a patient with DLBCL and HIV has an adequate CD4 count, in other words, more early in either his lymphoma pathway or his HIV treatment status, then these people did very well. But it's the patients who presented to us with low CD4 counts and not properly treated that did poorly. So we can see that the outcome was associated with this HIV status and CD4 count, and poor performance status of advanced HIV definitely played a role, and early diagnosis is mandatory, very important. And interestingly, this paper did concentrate on the subtype of disease and also seeing how it connects with HIV, but that was not significantly associated with outcome. So we speak about performance status and patients in the horizontal position when they get to us, and that is now exactly when they shouldn't get to us. They should get to us when they are still able to walk around and we can get that diagnosis done rapidly. Otherwise, we spend a lot of money and we may not be able to save our patients' lives. So on this pathway, we are conquering the good, the bad, and the ugly. How do we get to the happy ending for our patients? So that is what we spent a lot of thought on in the last few years. And key points from our research was that instead of facilitating diagnosis, fine needle aspirate cytology facilitated delays because there are a lot of misconceptions. TB is seen as a lone differential of lymphadenopathy in the community because TB is so widespread. But that doesn't mean we can completely forget about lymphoma. HIV causes doctors to actually approach a patient that is HIV negative as if they are HIV positive, making TB a much more common diagnosis, or the misconception is that it's a much more common diagnosis. Then there's the blind faith in cytology that's aspirated to diagnose almost anything, while in practice it's usually inconclusive, but it is not sensitive enough to denote absence of pathology. Then there is this lack of belief that anything malignant is worth diagnosing. So untrue. There is the belief that malignancy equals death, and we're being obstinate trying to treat it. Again, not true. There's also an ignorance of the necessity of urgent diagnosis, and that's, in a sense, our fault as hematologists, because we must make it just as important to diagnose lymphoma as it is to treat a heart attack. And then there's ignorance of the excellent prognosis of lymphoma. So we are on the pathway, and how do we improve survival? We focus on the access to diagnosis and doing the right things along the pathway. To get from the problem of lymphadenopathy to the solution of it, we are creating a pathway. And the very first thing we have to acknowledge is that the diagnosis of lymphoma is challenging. There are delays at both the patient and the healthcare provider level, and these occur due to many different reasons. There is a very insidious onset of most lymphomas. The symptoms are non-specific, and there is the great problem of TB, HIV, and other disorders mimicking lymphoma. There's also this huge problem of indiscriminate FNA use and the ignorance of the worth of comprehensive tissue sampling to reach a lymphoma diagnosis. The reported values shown in our literature in South Africa show that many patients are erroneously put onto TB therapy when they actually should have been diagnosed with lymphoma. And it's 25% Tygerberg, 88% in KZN, and 72% of HIV-positive Hodgkin lymphoma in our own hospital. So this means our battle cry has to be that healthcare workers do not have the required tools for diagnosis. And that is why they cannot diagnose lymphoma, but without the tools, they cannot refer a patient for diagnosis. So that is a very perfect recipe for something that is unsolvable, and how are we going to solve it? So let's look at 4 things that we can address. Is fine needle aspirate cytology a rule-out test for lymphoma? No, because tissue is and remains the issue for lymphoma diagnosis, unless you are dealing with a very, very specialistic aspiration lab, and we do not have that. So we have to go for tissue. Does a negative FNA equal empiric TB therapy? No, no, no. So how are we going to address this problem at a primary and secondary healthcare level without access to huge diagnostic tests? We will address it with a very simple adjunct investigation. We'll speak about that right now. Then the barrier to surgical excision of the lymph node being very high, especially in public health sector. Let's implement something that is evidence-based, used all over the world, and will mean that we do not use so much theatre time or need surgical expertise to such an extent. And that will be if we do point-of-care work with ultrasound and a biopsy gun. So the research work that we did is on this pathway, and the pathway neatly falls into 2 halves. We're addressing 2 huge problems. How can we be more diagnostically accurate when trying to rule in tuberculous adenitis or rule it out? Let's use the expert ultra. And the other half of the problem is, how do we get to a proper diagnosis of lymphoma and other types of cancer? We must sample the tissue using a point-of-care biopsy gun. So our prospective research in Groote Schuur Hospital meant that we set up these rapid access clinics to diagnose lymphadenopathy, fast and accurate. And our rallying call, or our battle cry, is this line shared by a doctor at a primary clinic who attended our first workshop. She said, "I do not know what is wrong with my patient, therefore I cannot refer to any specialistic service, yet I do not have the diagnostic tools to attempt a diagnosis myself." So we are closing this gap by using FNA Ultra Expert and the automated gun biopsy. And then we get an accurate diagnosis of these 3 great health problems. In the first place, using this expert ultra on the FNA as well as lymph node tissue, a quick point-of-care test, then we can get to the end of TB being the issue, and we can actually conclusively rule it in or out. If we use a point-of-care biopsy gun, then we also can get proper histological diagnosis. And sometimes that is necessary because tissue is the issue in certain lymphadenopathy cases. So the way that we approach these patients, and which would be also applicable to general practice, is if the lymph node is soft, that is the block on the bottom, soft, and or there's more than 5.5 ml of caseous material. In those cases, there will be an aspirate specimen, and we have now stopped doing smear microscopy because we feel that it's not useful, but the ultra is then being done on this aspirate. And ultra is very, very much more sensitive and specific, or sensitive than the AFBs and the culture. If we do not aspirate more than 0.5 ml of caseous material, in that case, we will go over to a tissue specimen and get histology, get the ultra, and get a culture. And if we think that the patient is likely to have a cancer, and that's typically the older patient, more than 50 years, we will also do an aspirate with a cytology, because in these cases, the cytology is very, very useful. So our first results that specifically looked at our TB outcomes shows that we could definitely diagnose TB in a proportion of patients, and we will look in the next slide at exactly what the percentage was of culture positivity in AFBs, and if we didn't have that, then we also looked at a composite reference which was made up of caseating necrosis, granuloma, or TB in another site. If it was not tuberculosis, we can see that lymphoma forms a large part of those patients, as well as some cases of metastatic cancer. So in our definite tuberculosis cases, they either were culture positive, they had AFBs, and in those cases, we can see the very, very good sensitivity and specificity of ultra, which was 86% if aspirate as well as biopsy was used. And we see the same thing in the probable cases, a very good sensitivity for the ultra. So what is our accuracy for TB diagnosis in this clinic? If we use this composite reference standard for TB, the ultra was 70% sensitive on FNA and 67% on tissue. If we compare that with the sensitivity, if we look below, for AFBs, that was 26% sensitivity on smear and 33% tissue, and then the culture only 39%. So we more than doubled our sensitivity to actually diagnose TB in these patients by using ultra. And that is a huge step forward for the diagnosis of TB on peripheral lymphadenopathy. If we look at the accuracy of TB diagnosis versus lymphoma diagnosis in this clinic, we can see that our three most common diagnoses in 110 patients evaluated so far, we had about a third of patients with TB, just under a third with lymphoma, and then a significant other proportion that did have disseminated malignancy in the lymph node. We could diagnose lymphoma in 84% of cases on a first attempt, and repeating it meant that we could diagnose lymphoma on a core in 94% of cases. So that is a very satisfactory outcome and compares very favorably with excision biopsy. And lymphoma could also be accurately typed, and they were our good old friends, Hodgkin, the good one, and DLBCL, the bad one. So compared with the historical cohort, the median diagnostic interval was significantly improved. So we could see patients, or we could get a diagnosis in 13 days compared to 48 days in our early work. And that is a huge, huge benefit for a patient if they can be diagnosed a whole month earlier. And the long waiting with FNAs that's done and redone and not leading to diagnosis can be cut out of the diagnostic pathway. So this is a very accurate and effective and doable pathway for peripheral lymphadenopathy in the periphery, in primary health clinics, in secondary hospitals, and also in other hospitals that offer definite care. This is a very fast and accurate way of diagnosing what the cause of an enlarged lymph node is. So we are all on the same team, and what the hematologists have done in this work is to take hands with the surgeons, with other specialists, radiologists, physicians, primary healthcare workers, and actually make sure that we address the concerns and use the expertise of everybody on this team So this initiative is starting in the Western Cape, and we are busy rolling it out. So the vision is to implement this pathway in different settings, public care, private care, and bring it into clinical practice as best care. To develop tools for education of healthcare workers from primary care to tertiary level, and to that end we are presenting workshops for education and hands-on training. We are also having videos of this training and the interventions and pathways necessary. We are offering online approaches to lymphadenopathy or lymph node masses and raising awareness to implement these interventions. So we want to make it known that there is no more reason in 2020 to do an FNA on a lymph node without doing expert if you want to rule out TB, or a cord biopsy if you want to rule out lymphoma. Those two things must be entrenched into best care for patients. And that is our goal, and that is our vision that we will make happen by exploiting this interdisciplinary nature of the pathway, getting everybody on board and getting a continuity of approach so that lymphadenopathy can be approached in the correct way no matter which level of medical care a patient can access. We hope that laying out this pathway has been very helpful to you as a healthcare practitioner and that it can be implemented in your workplace soon. Thank you.